Okay, I think we should start. Good afternoon from UK Kidney Association's working group, which has been discussing SGLT-2 inhibitors and generating a clinical practice guideline. My name is Herrington. I am an Oxford-based nephrologist and clinical trialist, and I am joined today by co-chair Andrew Frankel and two of the other working group members, Alex Riding and Alexa Wonnacott, who will all be presenting to you today this key guideline, which we believe is a paradigm shift in how we should be managing people with diabetic kidney disease and CKD with albuminuria. And we are presenting on behalf of a large working group of energetic contributors who are all listed below, who have all provided a substantial amount of time and supported nearly a year-long effort to generate the evidence, assess it, and generate evidence-based guidelines. So I'm incredibly grateful to obviously Alex and Alexa, and for Andrew and I working together. They have provided excellent support for this webinar. In terms of housekeeping, please would you respond to the questionnaire that will be circulated tomorrow. And importantly, we will have a didactic seminar where we will address your questions, but you do need to use the Q&A box within the Zoom function. So please enter your questions in liberally. And we will explain when in the agenda these will be addressed. But the key message, I think, for you is that we have a published guideline which is available for you on the UK Kidney Association website. Here's the URL, but if you simply type into Google UKKA guidelines, you'll find it. It's the top hit. And also we have, for those that are interested in analyses and data, the results of our systematic review, which has been meta-analysed by members of the working group and published open access. And I hope you'll find that it is an assimilation of all the SGLT-2 inhibitor data, both in CKD and non-CKD populations, and provides a comprehensive assessment both of efficacy and safety across the range of outcomes studied, including both relative risk reductions, but also importantly, absolute risk reductions. And it's been an immense amount of work, and I commend that to you who are interested in the data. These are disclosures of the co-chairs. Myself, I decline on an area, but I do receive grants from the charities and government organisations, and I manage grants for large clinical outcome trials, including grants from manufacturers of SGLT-2 inhibitors. And Andrew Frankel's disclosures are presented below. So the structure of the webinar is I'll just quickly provide you with an introduction and background to the guideline before Alex Riding will summarise the recommendations for use in people with CKD, and then we'll pause from some discussion, provided you've used the Q&A box. And then we'll move on to Andrew and Alexa's summary of implementation and safe use, including a brief overview of the licensing. And then we'll finish up with some further discussion to try and pull together really this call to arms to make sure that we start to implement SGLT-2 inhibitors in all patients who we consider would benefit. So here's a nice start, just a quick mechanistic summary for those of you that haven't heard of SGLT-2 inhibitors mechanism. Here is a nice slide that we've been showing for some time. So gliflozins is the other name for an SGLT-2 inhibitor, and they actually target the sodium glucose co-transporter on the proximal tubules. This diagram shows the gliflozin coming from the outside of the tubule in, but in actual fact, it's filtered through the glomerulus and comes in from the other direction and blocks the SGLT-2 co-transporter. So that co-transporter has functions of resorbing the vast majority of sodium and glucose in normal physiological conditions. So inhibiting it causes both a natriuresis and an osmotic diuresis, with glucose passing through into the urine. And of course, these drugs were initially developed for their glycosuric effect to try and control blood sugar in people with diabetes. But in actual fact, it's the sodium effects, and in fact, it's the increased sodium delivery to the sensing structure called the macula densa in the kidney tubules which is thought to be a key mediator of its benefit, or at least on kidney disease progression. And what happens at the macular denser essentially is an adenosine-mediated response causing afferent arteriolar vasoconstriction and reduced intraglomerular pressure, and consequently a reduction in glomerular pressure results in a reduction in albuminuria. And in time, this reduces risk of kidney disease progression in the studied populations that we have data on so far. So a drug that was designed to treat diabetes in actual fact has an effect on abnormal kidney physiology and reduces intraglomerular pressure. And biomechanism from RAS inhibition, which of course targets the efferent arteriole. So we're going to show you some of how this simple mechanism translates into clinical benefits. But first, I want to introduce the aims of the actual guideline itself. Our aim is to rapidly and safely introduce SGLT-2 inhibition into clinical practice in the context of our nephrology clinics, and also hopefully with those specialities that care for large amounts of people with chronic kidney disease, particularly primary care. And we provide guidance both on its use in CKD, focusing primarily on modifying risk of kidney disease progression, because of course this is one of the major effects of SGLT-2 inhibition, in addition to its effects particularly on heart failure. And we also aim to specifically support safe implementation. To do this, we have generated a guideline, but we recognize that the information, even during the course of the guideline construction, changed rapidly. And we did it such, it was a modular composition and could be updated regularly. So this is going to be a living guideline, and we're expecting it to have to change in the next 12 months as we get more information from the ongoing trials. And what you'll see within the guideline structure itself is recommendations not just for use, i.e. recommendations for who should be offered SGLT2 inhibition, but also recommendations for implementation, how SGLT2 inhibitors should be used. KDIGO have this concept of practice points. We were calling them recommendations for implementation. And then where there's uncertainty, we provide recommendations for research. And then to demonstrate you're effectively implementing, we also have audit recommendations, a much more standard structure. But we have these separate recommendations for use, which Alex will present shortly, and then recommendations for implementation, which Alexa will introduce for you later. Andrew has a nice summary of the regulatory licenses we currently have, but I also want to commend to you the guidelines full lay summary. So remarkably, the whole guideline has been essentially translated into language which is able to be assimilated by patients. And importantly, there are 2 participant information leaflets or patient information leaflets, one for people with diabetes and one for people without. And I personally have these available, and I'm giving them out like Smarties in my clinic because they're so useful, and I'm introducing this drug so often into the care of my patients. So at the beginning of last year, we started off by setting out on a journey of evidence-based generation, and this was done with a systematic review kindly set out by Andrew Roddick, who is a nephrology trainee with a particular interest in systematic reviews. The team identified a large proportion of the trials, in fact, hopefully all of the trials, and segregated out trials which were large, placebo-controlled, which generate the key evidence for use, but also trials in specialist populations that we think are relevant. So our transplant recipients, people with type 1 diabetes, people with preserved ejection fraction heart failure. And there are actually parts of the guideline which we don't cover in detail today for those subtypes of people using this information. But then, of course, we updated our literature research on the publication of one of the major trials, Emperor Preserved, in late August. And we identified essentially 11 major trials, from which there were 176 subsidiary publications. So an enormous amount of information that is being reported from all these trials and needed to be pulled together into a single document. Now, as a reminder of what these trials look like, so there are trials across 3 different populations. The first trials were in type 2 diabetes at high cardiovascular risk. The 4 in the middle, EMPA-REG Outcome, CANVAS, DECLARE, and VERTIS. And then we've had extensions into the chronic kidney disease and the heart failure populations, with 4 out of the 5 heart failure trials published, only 1 ongoing. and critically 3 out of the 4 CKD trials published, with credence and DAPA-CKD being kidney disease progression trials showing key results. Unfortunately, the SCORED trial, although very large and including an interesting type 2 diabetes population with and without albuminuria, was stopped early due to loss of funding, and the only provided information on cardiovascular outcomes didn't demonstrate benefits on kidney disease progression. And hopefully next year we'll have more information from kidney. And you'll see that our meta-analysis and the data we show you later segregates these populations so we can assess them separately and then compare them. And from these evidence, we generated grade 1 or grade 2 recommendations. Grade 1, we are strong recommendations and we use the term recommend. Grade 2 is weaker and we use the term specific suggestions. Because of the wealth of information, we were able to actually do something which is fairly unusual for a CKD guidelines, actually to provide recommendations for use, which are grade 1. And in fact, we have 3 grade 1A recommendations and 2 grade 1B recommendations to share with you shortly, in addition to a large number of recommendations for implementation. So I'll hand over to Alex now to present her slides. And if you just say next slide, I'll move them on for you, Alex.
Thanks, Will. So what I'd like us all to sort of bear in mind as we're thinking, as we go into the recommendations, is that although these are medications, you know, with a diabetic focus initially, actually, we know now that these are very useful medications for both our diabetic and non-diabetic patients alike. And in fact, game-changing really when it comes to renal protection and cardio protection. And just, I'd like you to hold that in your minds as we're beginning to go through the recommendations. So we'll start with our first grade 1A recommendation for use, and this is looking at patients with chronic kidney disease and type 2 diabetes mellitus. So as I say, in people with type 2 diabetes with an EGFR greater than or equal to 25, we recommend initiating an SGLT-2 inhibitor in those with a urine ACR greater than 25 attributed to diabetic nephropathy. Next slide, please, Will. And really, we can base this recommendation on the 2 major CKD trials. We've got credence and DAPA-CKD, and this table gives us an overview of the 2. So these trials, they were large clinical trials recruiting over 4,000 patients each, with the aim of looking at proteinuric kidney disease. For credence, that was diabetic proteinuric kidney disease. For DAPA-CKD, that was both diabetic and non-diabetic patients, but again, specifically recruiting those with albuminuria. For credence, the EGFR range for inclusion was 30 to 90, for DAPA-CKD 25 to 75. And as I've already mentioned, these studies recruited patients with proteinuria. In terms of the numbers that we'll be used to looking at, that's a urine ACR of just under 35 for credence and about 25 just under for DAPA-CKD. And the primary outcome for these studies was progression to end-stage kidney disease, a renal or cardiovascular death. And then for credence, a doubling of creatinine, and for DAPA-CKD, a greater than 50% sustained EGFR decline. Next slide, please, Will. So here we see, this is the result for the primary composite endpoint that I've just described. So clearly demonstrable benefits in these 2 CKD trials. We've got credence on the left and DAPA-CKD on the right. And here are the Kaplan-Meier curves, and we've got placebo in red and canagliflozin and dapagliflozin in blue on the left and the right on the screen. And clearly you see the lines dividing there, and beneficial outcomes for that primary composite endpoint in both cases for canagliflozin and dapagliflozin. And it's really this data that we can use that is relevant to our CKD population, and particularly with diabetic proteinuric kidney disease, that we can give that 1A recommendation for the use of SGLT-2 inhibition. Next slide, please, Will. So we're going to take a couple of recommendations together next. So here we have another grade 1A recommendation for use. So sticking with our population, our CKD population with type 2 diabetes, we recommend initiating an SGLT2 inhibitor in those with established coronary disease or stable symptomatic heart failure, and that is irrespective of ejection fraction. And then the second recommendation that we're going to take is on the next slide. This is a 2B recommendation, again looking at the same populations, so patients with chronic kidney disease and type 2 diabetes. We suggest initiating, because this is a grade 2B recommendation, so we suggest initiating an SGLT-2 inhibitor to modify cardiovascular risk in those with an eGFR 25 to 60 without proteinuria, so urine ACR less than 25, recognizing that the effects on glycemic control will be limited. And really it's that urine ACR less than 25 that means that we've downgraded our recommendation to a 2B, and I'll give you some data on that on the next slide. So I'll take a little bit of time to go through this plot because it looks like a lot of data all in one place, but we're looking here at the effect of SGLT2 inhibition on cardiovascular death or heart failure hospitalization. And this plot's taken from the meta-analysis that Will's already mentioned. You can find it at the link that is down to the right-hand side of the screen. And the data is arranged in 3 groups. We have our heart failure studies at the top. In the middle, we have the studies that recruited patients who had type 2 diabetes but were at high risk of atherosclerotic disease. And at the bottom, we have our chronic kidney disease studies. You can see there Credence and DAPA-CKD that we've already described, joined by SCORED there at the bottom. Our event line there runs vertically down the screen, and anything to the left of that means that SGLT2 inhibition confers benefit. And you can see, I think, very nicely from this data that the data is lying very much to the left-hand side of that line. In fact, for the heart failure group, you're looking at relative risk reductions in the sort of 25 to 30% region. For the middle group there, so looking at the studies for type 2 diabetics, specifically at high atherosclerotic risk, we're looking at sort of 10 to 20% risk reduction. And in our CKD populations in the studies to the bottom of the screen, again, a 25-30% relative risk reduction in terms of SGLT2 inhibition on cardiovascular death or heart failure hospitalization. So really supporting that 1A recommendation that we just described. Where it gets perhaps a little muddier is in our patients with without albuminuria. As I said to you previously, the Credence and DAPA-CKD studies actively recruited those with protein in their urine. However, SCORED didn't, and there are patients with limited or no albuminuria included within the SCORED trial. However, I should caveat the use of the SCORED trial in that it did finish early owing to funding concerns during the COVID pandemic. So where else might we find patients with low or no albuminuria? Within this context, I think therefore we look at the heart failure trials where just more naturally there will be people recruited to those trials with, as I say, low or minimal albuminuria. But of course, taking all of that together, we can only really justify a grade 2B recommendation for the SGLT2 inhibition in the context of modifying cardiovascular risk for those without proteinuria. Next slide, please, Will. So again, we're going to take the next 2 recommendations together. These are both grade 1B recommendations, and we're turning our attention now to renal progression. So we'll take the first one. So in people, again, with CKD and type 2 diabetes, we recommend initiating an SGLT2 inhibitor in those with a urine ACR of greater than 25 attributable to a non-diabetic cause. So this is similar to the first one, but actually we're talking about proteinuria here that we're not blaming on diabetic nephropathy. Next recommendation, please, Will. So again, this next one is another 1B recommendation, but this time we've changed our cohort slightly. We're looking at a CKD cohort without diabetes here. And we recommend initiating SGLT2 inhibition in those with, again, with proteinuria, so with a urine ACR greater than 25, excluding people with polycystic kidney disease or on immunological therapy for renal disease. So I should say, just before we go to the data, the 2 recommendations that we're talking about, most of the data for these comes from the DAPA-CKD study. excludes with a kidney transplant, polycystic kidney disease, those with lupus nephritis, AAV, or anyone who received immunological therapy for renal disease in the last 6 months. So because we've been very focused on ensuring that the recommendations are evidence guided and driven, we cannot therefore include those populations within this data. Now, thinking about these 2 recommendations, I'd like you to sort of, I think, consider whether or not it is a prerequisite to be diabetic for the effect of SGLT-2 inhibition on renal protection. And that's what we're going to think about in the next data slide. Please, Will. Because unfortunately, with the CKD data, there isn't enough of it to consider patients without diabetes in isolation. And so instead, we have to take the trials and combine them in order to drill down and get an answer to that question. And the trial groups that included patients who were both diabetic and non-diabetic were the heart failure trials and the chronic kidney disease trials. And you can see here, those are grouped: heart failure at the top, chronic kidney disease at the bottom, and then stratified. So instead of listing the studies, they are stratified instead by the diabetic status of the participants, so whether they had type 2 diabetes or not. And again, we're looking at a beneficial effect to the left of the vertical line. And I think, as you can see, the SGLT2 effect on it, we're talking about kidney disease progression in this graph, clearly beneficial with the use of SGLT2 inhibitors. But when we think about the data in this sort of combined way, and we think about the effect of diabetes, we can run a statistical test on it to ask the question, well, does it matter if somebody is diabetic on this kidney progression outcome? And as I say, we can do that statistically by running a heterogeneity test. And that's what you can see to the right of this plot. And you can see those p-values are not significant, indicating that actually it doesn't matter if you have diabetes or not, the outcome is still the same. There is still benefit with SGLT2 inhibition on kidney disease progression in both these heart failure trial groups and CKD groups. And I should say the heart failure studies, typically they are useful for us, for our kidney disease patients, because these studies recruited patients, I think it was Emperor preserved and reduced down to GFRs of 20, and for Deliver and Soloist to GFR of 30. So very much useful for us in interpreting our data. Next slide, please, Will. Okay, there we are, lovely. So this is the second piece of, thanks, Will, of evidence that we use for these 2 recommendations. As I said to you, the primary CKD study that helps us with these 2 recommendations is DAPA-CKD. And when we look at the analysis of this data by underlying CKD pathology, so on the left there, you can see at the top, the data has been stratified according to the underlying renal disease: diabetic nephropathy, ischemic or hypertensive nephropathy, glomerulonephritis, and other or unknown. And there are 2 lists there. The top one is for the primary outcome, which includes a cardiovascular death as part of that, as that composite, and then the kidney-specific outcomes, which of course were renal death, progression to end-stage renal disease, and the sustained GFR decline. And when we look at the effect of SGLT2 inhibition, we can see that the plots lie very much to the left of our vertical line, though the error bars are broad, and that simply reflects the reduced numbers within this data. However, I would like to draw your attention to the diabetic nephropathy and glomerulonephritis data, which for both the primary and the secondary outcomes are highly significant and therefore support the use of SGLT2 inhibition, both for diabetic and non-diabetic proteinuric renal disease. And when we again run the heterogeneity test to ask the question, well, does it matter what the underlying cause of renal failure is? The answer again is no, and you can see those tests to the right of the graph. Next slide, please, Will. So we're back to a grade 1A recommendation, and we're staying with our patient cohort of chronic kidney disease, but without diabetes mellitus. And in this context, we recommend initiating SGLT-2 inhibition in those with stable symptomatic heart failure, irrespective of ejection fraction. And again, because the data is more limited in the CKD population without diabetes, we're going to show you some data for this that's, again, combination. Next slide, please, Will. So this plot is different to the one I've just shown you, and that's because we're talking about cardiovascular death and heart failure and hospitalization for heart failure, not renal progression, as I showed you previously. But otherwise, the plot is set up very, very similarly. So we're looking at the heart failure trials at the top there and the chronic kidney disease ones beneath, with the data stratified according to the diabetic status. And clearly there is a benefit for the use of SGLT2 inhibition on cardiovascular death and hospitalization for heart failure. Again, a very wide error bar for CKD without diabetes, but that again reflects the low event rate. You can see just there 34 events within that category. And when we run, again, that heterogeneity test asking the question, well, actually, does diabetic status matter? The answer again is no, with those p-values there of 0.8 and 0.82. So that gives us confidence in recommending the use of SGLT2 inhibition to modify for patients with heart failure with CKD, but without diabetes. Thanks, Will. Next slide, please. So that brings us to the end of our data-driven recommendations. I hope that not too many people have data fog. We come now to our summary statements. As part of our literature review that Will introduced to you previously, we did look very hard for data to support the use of SGLT2 inhibitors in patients with kidney transplants. I know that's of great interest to those in the renal community. But unfortunately, there was insufficient evidence for us to make any recommendations either on safety or efficacy for those with kidney transplants. Similarly, there's, I think, an interesting scenario, and that's the use of SGLT2 inhibition in acute decompensated heart failure. But again, there was insufficient evidence for us to be able to comment on safety and efficacy. For those who want to find out a little bit more about these areas, please do go to the guideline and have a read of section 7. There are a couple of papers that are of interest, though they are very small studies. So there is a particular one for that we found for kidney transplantation, where I think it was 44 patients a year out from transplant with no DAT were given empagliflozin versus placebo. There's no data on clinical composite outcome. It was only 24-week study, but there was some positive indication that the drug lowered HbA1c in the treatment arms. For acute decompensated heart failure, again, there's another interesting study of 80 patients from, I think it was a Dutch study, using empagliflozin as an add-on therapy in acute decompensated heart failure. The study didn't reach its endpoint of dyspnea, BNP change and length of stay, but there is a hint that actually using SGLT2 inhibition in this context may mean that there is reduced rehospitalization for heart failure at 60 days. So I think two particular areas of interest, which I think moves us nicely, Will, next slide please, into the areas that we feel are under-researched and require more data. So firstly, it's whether the cardiovascular and renal benefits of SGLT2 inhibition extend to those with an eGFR that is less than 25. So DAPA-CKD went down to 25, and PKidney, of course, is recruiting down to 20. So we will hopefully have some more data on that soon. Secondly, whether the renal benefits of SGLT2 inhibition extend to people with lesser degrees of albuminuria. We talked about that in the sort of second block of recommendations, and actually that specific area has been under-addressed. But again, PKidney should give us more CKD specific data on that as that study is recruiting both proteinuric and non-proteinuric renal disease. Thirdly, the effects of SGLT2 inhibition on cardiac and renal outcomes in people with less well-studied non-diabetic causes of kidney disease. We looked at the stratified data from DAPA-CKD, but actually it would be great to have that more data. Again, that's going to come from EMPA-Kidney, and we really need to bulk that out to look at non-diabetic causes of CKD and renal progression. Next slide, please, Will. Our fourth research recommendation is really to consider the safety and the cardiorenal effects of SGLT-2 inhibition for those with a kidney transplant. There's also an unmet need for looking at the pharmacokinetics and again cardio and potential protection of residual renal function for patients who are on dialysis. And then finally, as we already alluded to, whether SGLT-2 inhibition in people with acute decompensated heart failure is safe and beneficial. And I think that's something that we would particularly need to think about in our CKD populations who might in that context be at greater risk of an acute on chronic kidney injury. Thanks, Will. Next slide. So I hope that wasn't too rapid a review of the recommendations and guidance, but I think what we'd really like you to take home is how the SGLT-2 inhibitors, that they represent a paradigm shift in the management of people with CKD. Credence and DAPA-CKD have demonstrated efficacy at reducing kidney disease progression, particularly in diabetic patients with albuminuric diabetic kidney disease. And of course, there's that evidence from DAPA-CKD in the subgroup analysis that these benefits really do extend to other causes of albuminuric CKD, and that these effects are irrespective of the presence of diabetes. And I think what is great, of course, is that although the effectiveness of SGLT-2 inhibitors at glucose lowering reduces as GFR falls, actually the renal and cardiovascular benefits remain preserved, which of course is great news for our kidney patients. Next slide, please, Will. So that takes us to the end of the recommendations for use and our research recommendations. And we thought it might be a good opportunity at this point to bring the speakers back. And for anybody who had a question about the recommendations or the intro, to ask it now.
Thank you, Alex. Really clear. Thank you for spending so much time explaining the forest plots, which, you know, they just immediately jump out to us, but they do look like branches everywhere to people on first look. So I've been sending chats to encourage people to ask questions that haven't been flooding in, but we have had a question about NICE guidance. Just to let you all know, thank you, Claire, for the question there. So Andrew is talking about licensing, but also will cover some of the NICE stipulations, which are of course important to encourage our primary care physicians to actually listen to our calls to prescribe. There's a question from Matthew about when we should stop them. That's an excellent implementation question. We will address that with Alexa. So yeah, so you're right, we haven't mentioned recommendations for stopping yet, but that's coming. And
although I think, Will, do you think Matthew's asking when we should be stopping them in terms of their therapeutic efficacy rather than if there were issues in terms of treatment? I suspect that's what he's talking about. Yes. And I suspect the answer is you may not be able to be certain about this, but do you want to say something about that, Will?
So some of it's covered in the licensing again, but if you think about the what was done in the Credence and the DAPA-CKD trials, patients with eGFRs as low as 25 were started on these treatments. It slowed progression, and that progression is, you know, the effect on the kidney is thought to be within the single glomerulus. And so the regulatory licenses, although they don't encourage initiation of SGLT-2 inhibitors below those eGFRs, I would encourage you, and they don't stop you from stopping the treatment when kidney disease progresses. There are good reasons to believe benefits will be preserved. In terms of the trials that have been done, in general, people who are transplanted have them stopped. So getting to end-stage kidney disease on the basis of a starting renal replacement therapy is a good reason to stop. but I have to admit that I do still encourage use of SGLT2 inhibitors in my patients. When they go on to dialysis, they're still passing good volumes of urine, and that's particularly true for patients with peritoneal dialysis, which may have some renal function you do want to preserve, and may well have to be coping with larger glucose loads. We do make that as a research recommendation, studying it in those groups, but certainly there's no mandate to stop them. So Matthew, I hope that answers your question. You can say yes or no, and we can come back to it later if we haven't. So Andrew, I have stopped sharing my screen and I can't see any more questions.
Well, there's Paul has just
Oh yes, I can, Paul. Yeah.
Yeah, so he's just asked comments on the ACR threshold and the
Yes.
measurement uncertainty of ACR. You did quite a bit of work with this in your bit of the group, didn't you? And looking at
Yes,
measurement.
Jim Burton and I scratched our heads on this an enormous amount. So we do have a comment on it, and because I predicted someone would actually come up with a question, I'm going to fly to the very end of the presentation. I think you should be able to see my screen still, and I've managed to jump so far forward. So this was one of the implementation recommendations from section 2 and 3, which is the use in CKD with and without diabetes, respectively. We do want to encourage people to follow NICE guidance. We do want to encourage people to start using UACRs regularly in our patients so that we have an assessment on them and don't have to wait for them. We suggested, given this implementation of a UACR above 25 milligrams per millimole, where there's clear evidence of benefit in people with type 2 diabetes and diabetic nephropathy, and where there is this grade 1B recommendation for people with non-diabetic albuminuric kidney disease, we do suggest that over a UACR of 70 milligrams per millimole, you don't need to confirm it. That demonstrates established albuminuria, and we would start treatment. For those with some of the issues with variability between 25 to 69, we do suggest confirmation. But of course, those without albuminuria may still benefit out from a cardiovascular perspective, and there is that grade 2B recommendation, which is based on EGFR alone, is irrespective of the level of albuminuria. So we're hoping that you will find a reason to give this SGLT2 inhibitor, or maybe more than one reason to prescribe them, and you won't have to spend too much time confirming UACRs to make sure there's an indication for use. So the wide-ranging indications that we hope you'll find at least one in our patients.
I did notice that Edwina's asked about, I hope Edwina feels that we've answered her question when we talked about stopping or continuing, and I hope she felt that we answered that.
Yes,
and
I wonder if Edwina agrees with our use in peritoneal dialysis.
Well, it's an area of real interesting potential research.
So we think use Edwina, yeah, because of the nephrons still benefit on a nephron level, unit level. I mean, we don't expect there to be major effects on of glucose, obviously, in terms of glucose lowering. So you're using it for risk. And what's interesting is even in the heart failure trials, simple subgroup analyses don't suggest that EGFR modifies cardiovascular benefits, which is surprising, just as it doesn't modify kidney disease progression, which is also surprising. So the benefits seem to be preserved within the limits of the data we've studied so far.
All right. So they're already onto this in Chile, I hear from Edwina. So that's interesting. And Jill, we will cover your question, but it's probably best we leave that until after we've done the next section, I think, because I think it will fit in more with that last part of the talk. So we will cover that.
Can I just make a comment about the urine ACR, just to say, you'll notice that it's the same cutoff for GFR and urine ACR, and that was a deliberate maneuver by the working group just to make, we wanted this usable guideline and easy to remember. But as Will pointed out right at the beginning, this is meant to be modular and fluid and to change with the guidance. So, as new data comes out and those thresholds change, I'm afraid those numbers will change, but they're not arbitrary. They marry up with the data, but we pick the numbers so they'd be easy to remember.
So Alexa is now going to tell us a little bit about how we use these drugs, having discussed when we might use them. Alexa.
Yeah, you can see my slides. Can you, Andrew? I'm sharing all right?
Absolutely.
Yeah, fantastic. Yeah, so I'm going to go through a bit of the nitty gritty now about how we actually go about implementing these drugs in our day-to-day practice. So starting with some very simple statements, really, and we've got a 1A grade recommendation here to suggest that we recommend using SGLT-2 inhibitors with demonstrated efficacy for their given indications. And we've got section 4 of the full guideline, which summarises what these current license indications are in use in the UK at the moment. And that includes the relatively recent and very long awaited license update for dapagliflozin for the use in CKD. We suggest that the beneficial effects of SGLT-2 inhibitor on renal outcomes in people with type 2 diabetes are likely to be a class effect, but there's insufficient data in people without diabetes to be conclusive. And what we mean by that is obviously we have a number now of large RCTs of patients with type 2 diabetes where the renal outcomes from either primary or secondary analyses are very, very consistent, which allows us to be very confident that this is a class effect. But certainly for the renal outcomes in the renal dedicated trials, we have far fewer trials for here. It's a single agent dapagliflozin in the DAPA-CKD trial, for example. And so we're less confident about the class effect here. But of course, we have got EMPA-KIDNEY in the pipeline. So hopefully when this is published, we'll be able to change the wording and possibly the grading of that particular recommendation. And then for the heart failure trials, much like the type 2 diabetes, we have a number now of large RCTs of different SGLT2 inhibitor agents, and each of these trials featuring a good chunk of patients without diabetes within them, as Alex has already said. And so therefore, we suggest that the beneficial effects of SGLT2 inhibitor on heart failure are likely to be a class effect, irrespective of the presence or absence of diabetes. And this forest plot just shows that rather nicely. Here we split the heart failure trials by the presence or absence of diabetes, and you can see that really it makes very little difference to what is overall a pretty impressive reduction in the risk for hospitalization for heart failure or cardiovascular death, with an overall relative risk of 0.76 or a 24% reduction for this outcome. And here we have a very similar graph now looking at the kidney disease progression from CKD trials, again, split by the presence or absence of diabetes, where of course credence and scored are exclusively in patients with type 2 diabetes. So it's just that DAPA-CKD trial, as we've discussed, with the cohort of non-diabetic patients. But as we've already heard, significant benefits in terms of kidney disease progression seen in both of those groups, and an overall risk reduction of 36% for kidney disease progression for this really important outcome, but with appreciating that fact that the number of events in that non-diabetic group within DAPA-CKD are on the small side, and therefore placing some caveats on the recommendations that we can provide for this particular group. We recommend using clinically appropriate single agent RAS blockade in combination with an SGLT2 inhibitor wherever RAS blockade is indicated and tolerated. And that's a 1A recommendation. And that's of course based on the fact that 100% of patients with credence, 97% of participants in DAPA-CKD were on maximally tolerated RAS inhibition. And therefore the benefits that we're seeing in these trials of SGLT2 inhibitors are obviously on top of the already well-established benefits of ACE inhibition. And the good news is that using these drugs in combination presents no problems in terms of hyperkalemia, etc. And now if we move on to some of our implementations regarding prescribing in diabetic kidney disease specifically. And this checklist here, really, these sorts of thought processes is not really any different to what our diabetology or primary care colleagues have been going through when starting their patients on SGLT2 inhibitor for HbA1c lowering effects. Except for us as nephrologists, it might actually be a little bit easier, and I'll explain why. First of all, we need to ascertain whether the patient has any active foot disease, and I will touch on the somewhat controversial signal for amputation with these drugs in a moment. But mainly it's about ascertaining whether this is a patient who is at high risk of developing ketoacidosis. So making sure that they are not patients with type 1 diabetes or maybe type 2 diabetes, but with particularly low insulin reserve. Checking, for example, that they haven't already had a previous history of ketoacidosis episodes in the past. And then there is a consideration as to whether these patients are on insulin or SU treatment, but specifically, is this a patient who has an eGFR of greater than 45 and an HbA1c less than 58 who are on these medications? In other words, what we're saying is this a patient who has an EGFR in which there will be an intact glycosuric effect of an SGLT2 inhibitor, which will mean that we're introducing an additional outlet for glucose in the urine, which in a patient who is already very tightly controlled in terms of their diabetic control may warrant slight relaxing of the either insulin or SU to avoid hypoglycemia. And this is where it's a pretty rare occurrence where having a lower EGFR actually makes using these drugs a little bit easier, because in our patients whose EGFR tends to be lower than 45 in our secondary care nephrology clinics, we aren't going to be seeing that glycosuric effect. So we aren't going to be introducing that additional outlet for glucose, and therefore we won't need to be tinkering with insulin and SU doses, which I think is quite a relief to a lot of nephrologists. And just to demonstrate that point, this is a nice graph taken from a paper by Cherney et al., which just shows that linear decrease in the ability of these drugs to actually affect HbA1c at all once the EGFR falls. And you can see that by the time your EGFR is below 30, the effects it has on HbA1c lowering are really negligible. So we do have some recommendations for those patients who have an HbA1c less than 58 and an EGFR greater than 45. And for those patients, we would recommend, or we're considering reducing the dose of sulfonylurea or meglitinide by 50% and reducing the dose of insulin by 20%. And these are the only medications that will cause hypoglycemia and therefore would warrant any dose reduction consideration. Other agents, your metformins, your GLP-RAs, your DPP-4s, they do not cause hypoglycemia. They are not going to require any tinkering of any doses. And also reassuringly, in our large meta-analysis of the big 11 RCTs, we found no increased incidence of hypoglycemia. In fact, we found a 13% reduction in serious episodes of hypoglycemia, possibly because of the anxiety of inducing it and therefore titrations having been made as per this slide. But to reiterate, the risk of hypoglycemia pertains only to those patients who have the higher EGFRs, the preserved glycosuric effect, and are additionally on either insulin or an insulin secretagogue. Patients who are not on these medications, there is no increased risk of hypoglycemia with using SGLT2 inhibitors. And just before we look at some of our implementations regarding DKA specifically, we're just going to sidestep a little here to just review the mechanism of SGLT2 inhibitor-induced DKA, because it's a little bit unusual. Obviously, we have this glycosuric effect that is going to lower our blood glucose levels, which will in turn lower our insulin levels. But it will also push our glucagon levels up, and that is going to increase hepatic glucose production, in part via glycogenolysis. Glycogenolysis will lead to a depletion in the glycogen stores, which means the body will enter a fasting-like state. That will initiate the liver doing fatty acid oxidation, generating ketones in order to provide an alternative energy source. But what SGLT2 inhibitors do in addition is that they increase the urinary loss of bicarbonate. So this, in combination with the increased ketosis, lowers the threshold required to induce ketoacidosis when there is an additional insult. This may be a dehydrating illness, diarrhea, vomiting, an infection, fasting period, big surgery, etc. But what is a little bit unique is that because we've got this glycosuric effect and this additional outlet for glucose, it is possible for these patients to develop ketoacidosis without the usual screamingly high blood sugars that we're used to seeing in our DKA patients. So it is going to require quite a high level of suspicion and a low threshold for checking blood ketones, pH, bicarb, etc. in these patients should they become unwell. And this is something that the medical community as a whole need to be aware of and probably reminded of intermittently, because this is a very rare side effect. We'll be looking at the absolute risks in a moment. And therefore, it is something that if we're not looking for, then we may possibly delay treatment for this. So something to just be aware of. So this is what the DKA recommendations look like. When initiating an SGLT2 inhibitor, we suggest that individuals should be advised on the signs and symptoms of DKA and instructed to temporarily withhold the SGLT2 inhibitors and seek immediate medical advice if symptoms develop. And we recommend that people with type 2 diabetes at greater risk of DKA should have SGLT2 inhibitors initiated with caution after discussion with the diabetes team. And these are the people that we're talking about when we're talking about a higher risk of DKA. It's those who are poorly controlled, it's those with lean diabetes with the lower body mass index, those with history of alcohol dependence, people who have rapidly progressed to requiring insulin, so really this insulin deficient phenotype, those of course with a history of DKA, and then some of the rarer causes of diabetes such as latent autoimmune diabetes in adults, which is quite commonly misdiagnosed as type 2 diabetes initially, but then have poor response to oral hypoglycemics, and then the so-called type 3 diabetes, which is primary pancreatic disease. And you're probably thinking, where are the recommendations, or where are type 1 diabetics in this table? And the full recommendations features a grade 1C recommendation to say that we should not be prescribing in patients with type 1 diabetes unless it is under the strict direction of the diabetes team. And at the time of writing that, dapagliflozin was the only SGLT-2 inhibitor in use in the UK that had a license for the use in type 1 diabetes as an adjunct to insulin. But as of literally a couple of weeks ago, AstraZeneca have pulled that from the license. And so now there isn't a SGLT-2 inhibitor license for use in type 1 diabetes in the UK. So the recommendation we've written still stands. We won't be using them in patients with type 1 diabetes, but it's just one of many examples of the headaches that we have come across in trying to write guidelines in what has been a really rapidly moving field. And Andrew will tell us a little bit more about the trials and tribulations of that later on. So what if a patient does develop DKA whilst on these medications? Well, we've got a grade 1A recommendation to say that SGLT-2 inhibitors should be discontinued when a patient develops DKA, and a 2D recommendation to suggest that after an episode of DKA and where a clear contributing factor has been identified, there should be a discussion with the person and the clinical team to establish whether the benefits of reintroducing an SGLT-2 inhibitor outweigh the risks. And then we've got a couple of low-grade recommendations here. They are around about fasting, and these are lower grade 2C and 2D because they didn't feature as any particular trial protocol, but we very much felt as a working group that this was a very common sort of real world scenario, and we wanted to provide some pragmatic guidance for that. And that is that we suggest that individuals taking SGLT-2 inhibitors should be advised against following ketogenic diet. And for those who do choose to intermittently fast, particularly if they are also elderly, they're on diuretics, or they have CKD, consider withholding the SGLT-2 inhibitor for the duration of the fast. And for those people with diabetes, ketone testing, of course, should be undertaken if they become unwell. And then finally, we have 1C recommendation about always offering advice on sick day guidance, not only at the point of initiating the SGLT-2 inhibitor, but also taking the opportunity to remind patients of these sick day guidance at every medication review. And I think, as Will has already mentioned, in the full guidance, we do have a couple of patient information leaflets. One is for people with diabetes and one is for people without. And in these, you will see a point-by-point description of the sick day rules. There's also information about signs and symptoms of DKA, when to withhold your SGLT-2 inhibitor, when to seek medical help, etc. So we really hope that you find those useful in your own practice, or can modify them for use in your own hospitals. So moving on to that, as I said, slightly controversial amputation signal. And we do have to acknowledge the existing MHRA safety notice for SGLT-2 inhibitors, but specifically for canagliflozin. And this was put into place after the Canvas trial identified a higher rate of lower limb amputations, predominantly toe amputations, with use of canagliflozin. And therefore, we suggest avoiding initiation in SGLT-2 inhibitors in the presence of active foot disease, and withholding treatment in those who should develop foot complications on treatment. We suggest a shared decision-making approach with appropriate counselling on the risks and the benefits of treatment, and also the importance of routine preventative foot care measures for anyone who is already at a high risk of amputation, and when thinking about reinitiating the SGLT-2 inhibitor after resolution of a foot complication. And these particular guidelines are very much in keeping with the guidelines written by the British clinical diabetologists published this year as well. And this is a forest plot then that really allows us to look at the magnitude of those two risks that are, arguably the two most, have had the most media and academic attention of SGLT-2 inhibitors. And for ketoacidosis, that is justified by an overall risk of around about a twofold increase in the incidence of diabetic ketoacidosis. But do note that the actual number of events is incredibly small. So the absolute risks are smaller. We'll come on to that in a minute. And additionally, note the line at the bottom of this slide here, which really should be highlighted in bold, and that is to say that in any trial where there were non-diabetic patients, there were no incidences of diabetic ketoacidosis. For amputation then, the increase in the signal here, the increase in the risk here in meta-analysis is entirely driven by that canvas trial, and that sits within that second diamond in the lower forest plot there. And actually, since the canvas trial, there has been no trial that has identified an increased amputation signal, including, of course, the renal dedicated credence trial, which was also of canagliflozin, which didn't pick up any amputation signal. But overall, there is a 16% increased risk in amputation, but that is attenuated to a non-significant 6% increase if you exclude that canvas trial, which we haven't done here, but we have done that in our published meta-analysis if you want to take a look at that. And this is a really great way of looking at things, looking at the absolute risk, so that we can really put those risks and benefits into perspective side by side. And what this does is look at the absolute risks in the two groups listed here, those type 2 diabetics in the high cardiovascular risk trials, but also in the albuminuric CKD trials. And you can see here, starting with the side effects seen in red that we've been discussing, that for every 1,000 years of SGLT-2 inhibitor use, we can expect to see an additional 0.7 or 1 amputation events in the type 2 diabetic or the albuminuric CKD patients respectively. And for ketoacidosis, for every 1,000 years of SGLT-2 inhibitor use, we can expect to see an additional 0.3 ketoacidosis episode in both groups. Now compare that to the preventions we are seeing in kidney disease progression, heart failure hospitalization, cardiovascular death, MI, AKI, and note as well that the benefit, the risk benefit seems to be even greater in the albuminuric CKD patients, with all outcomes being better apart from the myocardial infarction, which seems to be more pronounced in the cardiovascular risk trials. And there is also an additional group that we're desperate to include into this table as soon as EMPA is published, and that would be the albuminuric CKD trials in non-diabetic patients. And just to give you an idea, based on DAPA alone, and this is all featured in our meta-analysis, the equivalent numbers for this would be 19 fewer kidney disease progressions, 3 fewer heart failure hospitalizations, and 3 fewer cardiovascular deaths, with 0 increased ketoacidosis and 0 increased amputation, or at least incalculable risks of those. So it seems to be that in this group, an even more of a no-brainer in using an SGLT-2 inhibitor in terms of looking at those risks and benefits, but with that very important caveat that we're talking about a very small number of patients at the moment, and we're so excited to see what EMPA Kidney can come up with, and then we can formally include that as a line in this table then. We do have some recommendations as well with regards to AKI and monitoring, and these are that we recommend that individuals initiated on an SGLT-2 inhibitor do not routinely require an early assessment of renal function or potassium after initiation of treatment, and that should an individual incidentally have a renal function assessment within the first few weeks after initiation, a decline in EGFR needs to be interpreted with caution and in the context of an expected drug effect to avoid unwarranted discontinuation. And this is, of course, a statement made in appreciation of the fact that that EGFR dip that we see in patients in that first 3 to 4 weeks after initiation is reflective of those favorable hemodynamic modulations in the glomerulus that Will has talked us through, and therefore should not be interpreted as an AKI signal. On the contrary, in meta-analysis, what we can see is that it does appear that the use of SGLT-2 inhibitors is associated with being protective against AKI, with overall a 30% reduction in the incidence of AKI in the SGLT-2 inhibitor groups. And note as well that that includes the heart failure trials, where we saw a lot of use of high-dose diuretics and a lot of co-prescription with MRAs and the ACEs, of course. And even in this group, we're seeing reductions in AKI. So we're not 100% certain what the mechanism of this is. It is hypothesized that it's down to reduced metabolic demands on the proximal tubule by blocking that high ATP demanding sodium glucose pump. What we're doing is if you like, allowing the proximal tubule to have a little bit more in the reserve tank to deal with hypoxia and ischemia reperfusion in AKI perhaps. But we look forward to more research to finding out a little bit more about that. And then finally, coming on to some of the recommendations regarding the concerns over glycosuria-induced thrush. And these are that all people are counselled on the risk of mycotic genital infections prior to initiation of SGLT-2 inhibitor. Specifically, they're counselled on self-care to maintain good genital hygiene, but also symptoms of genital infections and how to seek help and self-manage. And again, as with amputation, we are obliged to highlight the MHRA warning for Fournier's gangrene and suggest that all people are counselled on the symptoms of this and advised to withhold, to stop SGLT2 inhibitor and seek urgent help if they develop. And that is a 2D recommendation. And that's based on the fact that from the trial data, there were very, very few instances of Fournier's gangrene, so few in fact that it was impossible to draw any statistical inferences at all. And actually this MHRA warning has come from a handful of yellow card notifications in post-marketing surveillance. And so to date, there hasn't been a proven link between SGLT2 inhibitors and Fournier's gangrene, just to keep that in mind. And here's the forest plot looking at that risk of mycotic genital infections, and it's around about a 3.5-fold increase in thrush. And our full guidance also features a recommendation that one would, in the instance of having thrush, continue the SGLT2 inhibitor and simply treat the thrush as you would do usually. And now I'm going to hand back over to Andrew, who is going to talk a little bit about the barriers to implementation that we've certainly experienced, and I'm sure many of you have as well. So if I stop sharing now, Andrew.
Thank you very much, Alexa. So, hopefully that can now be seen. I wanted just to finish this whole webinar with just a little bit about practical issues. I think that, and I hope you've all now got the very clear message, as Will has said, that this treatment, SGLT2 inhibitors, is a paradigm change in our management of people with CKD, and particularly proteinuria CKD. And getting the message across that if you put people on this medication, you will get additional to the benefits of a RAS inhibitor, another 30 to 40% reduction in progression of CKD over a period of 2 to 3 years. And that is even if you take away the issues around the benefits for heart failure. And so I think the key message to us as a renal community is we now need to get this out and get this implemented as rapidly as possible across the system, remembering that most of the patients who stand to benefit from this treatment are actually probably currently under the care of primary care. Now, when we start to actually try and do this, of course, we're often scuppered by what I call the politics and the limitations. And these relate to issues around license, NICE recommendations, the real evidence, and they all need really to be adjusted and recognized in terms of our determination of what we need to do to get this treatment out there for our patients. Now, actually, I am incredibly optimistic that the system, the whole system, recognizes that we have this paradigm shift ahead of us and that we need to get this implemented. And we are seeing rapid changes in some of what would previously have been the limiting issues that would prevent us using these medications. However, please remember, this is a rapidly changing area. We're going to see a new license for empagliflozin in relation to the Emperor Preserve study come out in January, and we will see other new licenses emerge as other evidence appears. This is a very brief and summary, and I thank Alexa for this, reminder of the current license. And I think this is up to date, but you know, it really does change pretty rapidly. And you do need to look at each individual drug's current license to ensure that when you decide a person with heart failure or kidney disease needs an SGLT2 inhibitor, you are prescribing it with using the drug that has the license freedom to do so. And I know it's complicated, but there are drugs that will be available for all of the recommendations that we have made within our study. I want to underscore this with the two recommendations that we've made in the guideline. One is, as I've just said, use the SGLT-2 inhibitor that is licensed for that individual and its use. But also, I want to remind you that we believe that we will find that this is going to be a class effect. We will probably emerge to that view over a period of the next 5 to 10 years, which is why at the present time, we still need to go according to license. Now, if we are going to start recommending this across the system, we need, as many of you know, to have the support of NICE. And I can tell you that, being a rather cynical person, particularly NICE's, in relation to NICE's diabetes guidelines, which I know probably more about than I do about some of the renal guidelines, they haven't really covered themselves with glory there over the years. But they have actually produced pretty good NICE CKD guidelines. And the very good news is that NICE are moving, and they are now beginning to present what I would describe as a joint up approach to the use of SGLT-2 inhibitors. And if you look at the new NICE CKD and diabetes guideline, NICE are very clear that adults with type 2 diabetes and CKD who are taking an ARB or an ACE inhibitor should be offered an SGLT-2 inhibitor if the ACR is over 30 and they meet the licensing authorization, i.e. use the drug that is licensed. So they've taken a similar view to us. And for adults with type 2 diabetes and CKD taking an ARB or an ACE inhibitor, you can consider it at lower levels of ACR. So they are moving very much towards, and I'm pleased this all came out because it came out actually after we produced the guidelines, to something that's a little bit more consistent to our guidelines. And I think I can say this hasn't come out now, but this is what is being consulted on. That in relation to the DAPA-CKD technology assessment, they are now recommending this as an option for treating chronic kidney disease in adults, again, as an add-on to standard of care, GFR to initiating at GFRs above 25 and ACRs above 22.6, but for diabetes, ACRs of more than 3. So actually, the stars are beginning to align in relation to NICE, into what the license allows us, and in relation to what the evidence suggests that is articulated within our guideline. So you will now be able to recommend these treatments for the patients that you are seeing in your clinics, and for the patients that you are working with primary care who are sitting in primary care. And don't forget that when you see your patient, not only do you need to consider CKD, but in most general nephrology clinics, around 40 to 50% of people with diabetes and CKD have got heart failure. Many will have heart failure with preserved ejection fraction. And given the EMPEROR preserved, we've actually no longer distinguished this. And this will be another door through which a patient can go through to get their SGLT-2 inhibitor. So what I would like to close with is to ask you as the audience to take on 3 challenges. First of all, and you started this by coming here today and attending this webinar, develop confidence, develop expertise in the prescribing and the recommendation of SGLT-2 inhibitors. And that's just not important just for your practice, but it's important also in spreading the word across primary care. We need to ensure that every individual who will benefit from this treatment receives this treatment and receives it soon, given the 40% reduction in progressive CKD. And the only way it's going to happen is for us to start working not within silos of general nephrology clinics and secondary care, but to work across the system and to work with primary care, the evolving ICSs and the system. So I remind you of where you can go to read the guidelines, and also if you wish to review the meta-analysis that underscored much of the guideline recommendations, and to provide you with significant resources that will help you and help primary care introduce these medications. Thank you very much, and I'm going to stop sharing. And perhaps my colleagues can join us again, and we did want to finish ahead of time. So, will any questions?
There are some questions, Andrew. There's a question from Jeremy Levy. Hi, Jeremy. He obviously supports the widespread use, but has raised the genital mycotic infections, it being a real-world issue. And he says that there's experience from GUM clinics with lots of people with diabetes on SGLT-2 inhibitors and seeing significantly more thrush. So a symptomatic side effect versus an asymptomatic benefit, I think analogous to muscle aches and statins maybe, but in this case, probably a true side effect. I have to admit that I have had balanitis in patients I've started it on, and sort of refractory balanitis, but it does, get treated. I do temporarily stop the treatment if I have to. And I've heard that some people provide a, canistin, very low cost now, with prescriptions to SGLT2 inhibitors. I don't, because it's not a universal complication. In your implementation section, the safety, did you think about that? Comment on that?
Yeah, I don't know. Alexa, do you want to comment on that? Or
yeah, we definitely did consider this, and actually, I didn't mention this recommendation, but as much as we do say, as you say, continue it through an episode of thrush. If recurrent thrush is an issue, we do also make a recommendation to consider prophylactic antifungals in these patients. But completely agree with you, Jeremy. It's going to be the patients, if they're experiencing a lot of discomfort from this, then that might be a bit of a deal breaker for them. And I guess that's down to us as clinicians to be able to communicate those benefits in terms of the cardiovascular and the renal protection to them in clinics. And hopefully some of the information in our patient leaflets that we've produced can be helpful in that regard. But we take your point, and it's something that we did consider. And that's how we've come up with the recommendations. In the end, it's just to offer that option of prophylactic antifungals if it's a persistent problem.
I think it's worth adding also that there are some symptomatic benefits. I have had patients who've had very substantial improvements in their edema. I've had patients who have lost some weight, and so it's popular for those reasons alone. Also to add is that I was very concerned about this for starting an SGLT2 inhibitor trial, but with empakidney, reasons for stopping being cited as developing a thrush or mycotic infection are incredibly small.
I think that, Will, is the general finding from many of the randomized studies, that that as a reason to stop is small. But I suspect in the studies it's because you are A, warning the people properly in advance, and B, managing it speedily. If you start an SGLT2 inhibitor and you haven't covered it and it comes as a surprise, you lose that confidence. And I think it can be managed with appropriate counselling with the patient.
I've been to the pharmacy recently, but I think a tube of canistin is not particularly expensive nowadays, £1 or £2.
So Claire is highlighting, absolutely, that was my sort of call to arms, Claire, about working with primary care. They're going to need a lot of our support to do this. Although remember, primary care has been prescribing SGLT2 inhibitors for many years. It's about them getting their head around the fact that this is not being used for diabetes, this is being used for cardiorenal protection. But otherwise, it's very similar. And the extent of the benefits, I think, is inarguable. So we do need to work with primary care to get this implemented. I don't know if there are any other questions. Yes. Oh, so Jill, and that was covered, yeah. in our guideline, there is very good study to show that if you can give people good advice on genital care, you significantly, and I was quite amazed how significant this was, you significantly reduce the incidence of genital infections. Well, Will, I think if we've not got any more questions, this may be a time to A, thank Alexa and Alex, who've done a lot of the work. B, thank the UK Kidney Association for allowing us to present. And C, thank you as an audience, who I hope will now go out there and spread the word about SGLT-2 inhibitors. Oh, I've just seen Daniela's asked, and I'll answer that by typing about monitoring. The monitoring is all covered, Daniela. Definitely start as an outpatient and test blood when you next need to test the blood. You don't need to do any extra monitoring. Okay.
Despite what NICE suggests,
yes,
it's being used, you know, I start this in outpatients. I don't do any extra monitoring beyond what's necessary, except for people who I am concerned about hypervolemia, which in my CKD clinic, unfortunately, is very rare.
Okay, so with all those thanks, which I won't repeat, we're going to say to everyone good night and thank you very much for joining us. Good night.